Okay, this slide shows you some of the important year 3 topics in surgery, which you must be familiar with during the 6 weeks of surgery. Evaluation of the important symptoms and history. Okay, these are the 10 important topics that you must be able to be familiar with. Abdominal pain, assessment of a patient with abdominal pain, abdominal mass, breast mass, neck or mass anywhere else, upper GI bleeding with hematemesis and melena, lower GI bleeding with colorectal bleeding, blood stains, stools, and hematochezia, hematuria, jaundice, especially obstructive jaundice, also called surgical jaundice, inguinal hernia and groin swellings and inguinal scrotal swellings, varicose veins, peripheral arterial disease, and non-healing ulcers, or especially of the leg. Then, as far as the signs are concerned, very important. These are the 6 important uh, subjects or topics for examination. Neck and thyroid, which we'll be covering today. Breast and lump and axilla, breast lump and axilla examination. Examination of the abdomen, especially patient with pain or masses, how to go about assessing a patient with abdominal problems. Examination of the inguinal hernia, incisional hernia, or groin swellings, especially inguinal scrotal swellings. Varicose veins and leg ulcers, non-healing ulcers, how to assess a patient with varicose vein and leg ulcers, and also to examine a patient with peripheral arterial disease, PAD. So these are the 6 important uh, topics you must be able to examine the patient to obtain the various signs in these patients. Okay, in today's clinical series on examination for year 3, is the first lecture today is thyroid examination. I shall also go into a bit more detail on general examination of the neck. So this is a simple examination of the neck and thyroid. And this is a very important topic for exams, clinical examination, where you are expected to know how to, in detail, how to take a history and examine the patient for one with thyroid problems. Before we go on with the examination proper, it's very important to understand the basic anatomy of the neck and the thyroid. Okay, on the picture on the left here, it shows the general layout of the thyroid here. Okay, it is in the anterior aspects of the neck, in front of the trachea, as well as the esophagus. Okay, it overlies the C2, 3, and 4 cricoid cartilages. Here you can see C2, 3, and 4. There's a right lobe and a left lobe, and both these lobes are connected by the isthmus, which overlies the third cricoid cartilage. Okay, tracheal cartilage, and it extends from the lower border of the thyroid cartilage here right to the C5 to C6 tracheal rings. So these are very important landmarks. And on the right here, it shows you a bit more details here. There are 2 main structure areas that are important anatomically in a patient's going thyroid surgery. Upper here is known as these are the 3 main structures here. Number 7, which is your superior laryngeal nerve in yellow here. Then you have got your number 14, which are the vessels, blood, artery, and vein, known as this is number 14. You can see number 14 here, superior thyroid artery and vein. So here, superior laryngeal nerve, superior thyroid blood vessels. And the other important structure is in the lower pole. Over the lower pole, you have got these areas which are marked here. Number 4 is your inferior parathyroid gland, the lower pole of the left lobe of the thyroid. Then you've got your recurrent laryngeal nerve, very important. 6 recurrent laryngeal nerve, which is the branch of the vagus nerve as it curves around the arch of the aorta. Okay, this is your recurrent laryngeal nerve. And the third one, important one, is your inferior thyroid artery and vein. Okay, inferior thyroid artery and vein, number 13. Okay, actually is so this is very important. So these are the three things, three structures in the lower pole and three structures in the upper pole that are important. And I said thyroid consists of a right lobe and a left lobe joined together by the isthmus, and sometimes there's another lobe known as the pyramidal lobe of the thyroid. Okay, from the isthmus it goes upwards here. It overlies the trachea. Thyroid overlies the trachea. Okay, now we come to the first thing that we want to do, examine a patient, is take a proper history. Okay, history taking, okay, looking for the symptoms of thyroid problems. First one, the most common symptom of the patient is swelling. Patient, most of the time they come complaining of swelling. The swelling can be localized or diffuse, smooth or nodular, which is very important to get the details. The onset of the swelling can be acute, subacute, chronic or acute on chronic. Very important. The swelling or onset of the swelling. So if the swelling is chronic, then it's a different diagnosis. If the swelling is acute, then we think of some other conditions. And the other important thing is pain. Whether this swelling is associated with pain or painless swelling. Okay, and then the progression of this swelling, rapid or slow progression. Does it grow in size or is it static? Rapid. Okay, these are all important features that you must look for. And then pressure symptom. Okay, pressure of this thyroid onto the structures adjacent it, and usually is the recurrent laryngeal nerve, which leads to hoarseness of voice, the esophagus leading to dysphagia, and pressure on the trachea can lead to stridor or patient complain of breathlessness. The other important symptom is altered function. Can be hyperthyroidism, thyrotoxicosis, or hypothyroidism, mixed edema. See whether these patients have got signs or symptoms of hyper or hypothyroidism, which you must be familiar with. Next, symptoms of metastasis. Okay, cervical lymph node enlargement, the 7 levels of lymph nodes which we will go through later, and whether there are metastasis, symptoms of metastasis, especially to the bones and lungs, where they can cause bone pain and breathlessness. And other important thing is constitutional symptoms. When you think of malignancy, then you have to think of constitutional symptoms such as fever, malaise, lethargy, and severe loss of weight. The second part is which we are primarily concerned with today is the examination of the thyroid. As can you see here, clinical examination of the thyroid. So first of all, you have to greet the patient, position the patient. The ideal position for the patient is to sit on a chair. Okay, inspection from the front, also palpation also from the front. Check for whether it moves with swallowing, whether it moves with protrusion of the tongue. To do this, sometimes you may have to give the patient some water to drink. Then you go to the back. Okay, so palpation of the lump from the back, the lump and the thyroid. Okay, and also palpation of the cervical lymph nodes. So from the back here, like as shown in this diagram here, patient at the back using his fingers to palpate the neck for the thyroid as well as the lymph nodes. Then you look for retrosternal expansion, and this is usually done by examination from the front, presence of a systolic bruit, okay, especially for toxic goiters where there's an increased vascularity, so you may be able to listen to a bruit. And then, as I said, hyper and hypofunction signs. Signs of, just now you look for symptoms of hyperthyroidism, now you look for signs of hyperthyroidism, okay, which we shall highlight to you in another slide. Then the other important thing is a special test that you can do for these patients. Some of them, Pizzillo, Coccus and Pemberton sign. Okay, then come to what are the signs that are usually you look for in patients with thyroid. Okay, so most important is a lump, is a goiter. Okay, goiter is generally a diffuse lump, diffuse swelling of the thyroid. It's a palpable thyroid. Normally, thyroids are not palpable. It can be diffuse or it can be multinodular. And if it is nodular, it can be a solitary nodule or can be a multinodular goiter. So this is very important. This is the main feature of a presenting swelling of a thyroid. Okay, lump, solitary nodule, multinodular, diffuse. Location of the lump is very important. Right side, left side, bilateral, central in the isthmus. Consistency, okay, soft, firm to hard. Whether it moves with swallowing and protrusion of the tongue, or is the lump itself mobile on digital palpation, whether it is solid or cystic, and whether note the size of the lump, and has it been growing from the history. Then you look for tenderness, very important. Thyroiditis, usually the thyroid is very tender to touch. Then the special test which I mentioned, Pemberton, Prisillo. Then look for tracheal deviation, retrosternal extension, percussion by percussion. Thyrotoxicosis and thyroid hypothyroidism signs are important. Okay, and the cervical lymph nodes, palpating the cervical lymph nodes. There are level 1 to 7 cervical lymph nodes. So are the lymph nodes palpable? It's very important. So these are the lumps or the signs that you look for in a patient with thyroid swelling. Okay, then we come to details of the examination. Okay, examination of neck. As I said, first you greet the patient and position the patient. Ideally, the patient must be sitting on a chair as shown here. So inspection from the front, you do the inspection and palpation. Okay, locate the lump, any obvious swelling, all this you inspect, and also you can even palpate from the front. Okay, so from the front you got look for any lump size, shape, movements, swallowing, movements with swallowing, and tongue protrusion. Look for Pizzillo and Pemberton sign, skin changes, and palpate for tenderness. If there's tenderness, locate the site of the tenderness. Then the second part is at the back, examining from the back here, patient sitting on a chair. Okay, palpation again, you can reconfirm what you saw from the front. Look for retrosternal extension, movement and swallowing, and protrusion of the tongue. Check for the cervical lymph nodes, especially the deep cervical lymph nodes. Describe and palpate these lymph nodes. Carotid pulse, which is also causing obliteration of the carotid pulse. That's a Berry sign. Pressure on the trachea leading to breathlessness, Coccus test, and also check for the bruit, auscultate for your bruit or thrill. Then the third part, again, you come back to the front to examine the patient. Okay, tracheal, look for the tracheal, the position. The trachea must be central, whether there's any tracheal deviation, whether there is any retrosternal extension of the goiter or thyroid into the upper mediastinum, signs of hyper and hypothyroidism, and the special test. Okay, so these are all done from the front and the back. Once you have got all these, then you summarize the physical findings and come to a possible diagnosis. Okay, so very important. Front, back, and again from the back again. This is how you palpate the thyroid. Okay, these are some pictures to show you palpation from the front, from the back. This is again from the front, and here looking for the cervical lymph nodes from the front. Okay, so it's a combination of palpating from the front and back. Next, checking for the tracheal shift. Okay, tracheal shift. The trachea should be central. Is midline here, below the thyroid cartilage here. Okay, you can see here it must be central. If it is deviated, in this case the trachea is deviated to the side, there is a gap here which can be felt with your finger. Here the trachea deviated to the right, so there's a gap here. Okay, so this is how you check for the tracheal shift. This is important because pressure by an enlarged gland, thyroid gland, can cause shifting of the position of the thyroid. And these are some pictures to show you again. Inspection from the front. This is with swallowing. You inspect from the front, ask the patient to take some sips of water. Or patient from the back, and here looking for the tracheal deviation. And this is general. The position, the picture shown just now. Patient sitting on a chair. You go behind and using both your hands to palpate the thyroid, right and left side. So these are the summary of the steps in the examination of the thyroid. Inspect the neck, ask the patient to swallow, palpate from the back, flex the neck slightly to make the muscles relax so easier to palpate. Palpate both lobes and the rest of the neck for lymph nodes, the additional test which I mentioned just now, and then look for general and peripheral signs of thyrotoxicosis or hypofunction, hypothyroidism, and especially look for eye signs of thyrotoxicosis. So again, here, this is a patient with a large nodule on the right. This is a solitary nodule on the right lobe of the thyroid. This is the larynx, this is the trachea, and this is the cricoid cartilage. This is other two cartilages on which the thyroid lies. Now, the special test now. What are the special tests that you have to do for this patient? First is your Pizillos test, known as the Pizillos method, and this is usually done for patients with short neck. Alright. Pemberton sign, face congestion of the face on lifting the arms above the head. Okay, both the arms, and this is to detect the congestion of the thyroid in the the main veins at the entrance of the inlet of the thorax, especially the brachiocephalic vein and all that. So as a result, they cause congestion. Then this is your Pemberton sign. Berry sign, press on the carotid. Pulse becomes absent when you press on the lump. Okay, the thyroid lump. Cocker sign, same thing. It is the lump is pressing on the trachea. So when you press on it, it develops obstruction and leading to breathlessness and stridor. Leahy's method, examination of each lobe in detail, and this is usually done from the front. Kreil's method, using the thumb, okay, to press on the gland and details and ask the patient to swallow. You can also detect determine the surface and tiny nodules in the gland, thyroid gland. Then Horner syndrome, due to pressure on the cervical sympathetic nerves, meiosis, ptosis, anhidrosis, and ophthalmos. Okay, these are important things that you must look for in these patients. Okay, these are some special tests or maneuvers. This I told you is the Pemberton sign. Raise the hands above, the face becomes flush. And this is due to pressure of this large goiter on the great veins at the inlet of the thorax here. When the veins are compressed, the venous return from the head and face reduces, and there you get congestion. This is Pizillos method, especially for women with short neck. Extend the neck like this, and then any lump in the thyroid becomes more prominent. Okay, this is the Kreil's test, where you use your thumb to examine in detail any small nodules in any lobe of the thyroid. And this is your Cocker's test, where you press on the lump, and if it is pressing on the carotid artery, then the carotid pulse becomes reduced or absent. Okay, next we come to the functional disorders of the thyroid: hypothyroidism and hyperthyroidism. Okay, more commonly we see hyperthyroidism. In hyperthyroidism, all the functions in the body are elevated, increase. Rate of function becomes increased, metabolic rate becomes increased. And the common signs, although the long list is here, the common signs will be bulging eyes, exophthalmos, goiter and large thyroid, palpitations, tremors, heat intolerance, very, very important, sleep problems. Okay, patient usually is unable to sleep, very anxious. Okay, he has got insomnia. Patient has got diarrhea, okay, due to hyperfunctioning of the intestines. Patient may have menorrhagia, okay, increased periods. Sweating, excessive sweating, patient becomes, you're sitting, you can see the skin becomes very wet due to the sweat, and patient is very, very anxious, okay, easily gets angry, easily irritated. So these are all the features of these are the 10 common features of hyperthyroidism. On the other hand, in hypothyroidism, there's a decreased function, there is all the functions of the body becomes depressed, decreased. Okay, so there's goiter, bradycardia, cold intolerance. Here heat intolerance. Now here is hypo is cold intolerance, weight gain, dry skin, puffiness, constipation, irregular periods, sleep, and hypercholesterolemia. So these are the two groups of symptoms that you must go through with the patient. Okay, when there's increase is hyperthyroidism. When these symptoms are decreased, then you get hypothyroidism. Okay, those of you who like to use mnemonics to remember, okay, this is the word that you use, thyroidism. T for tremor, H for heart rate, increased heart rate, fatigue, yawning, Y for yawning, fatigue, R for restlessness, a patient becomes very irritable and anxious. O is for oligomenorrhea, okay, decrease period or changes in periods, okay. Then you've got intolerance to heat, I, D for diarrhea, I for irritability, S for sweating, and M for muscle wasting. So these are all the features of hyperthyroidism, a patient with a goiter which presents as hypothyroidism. Okay, now we come to the other important structures in the neck that you are interested in, okay, and that is the lymph nodes, cervical lymph nodes. Cervical lymph nodes are very, very important, not only for thyroid patients, for patients in general where metastatic lesions can spread to the neck. Okay, so these are the cervical lymph nodes that we are concerned with. Okay, you've got 7 levels, 1, A and B. Okay, 1A, 1B, okay, 7, 1, 2, okay. This is your submental and submandibular glands. Then you got your 2, 3, and 4. These are the deep cervical lymph nodes. Upper deep cervical, middle deep cervical, or lower deep cervical. So these deep cervical lymph nodes, also known as the jugular lymph nodes. Okay, they are very important. Then you have got your group 3 and 4, that is 2, 3, 4 will be your deep cervical lymph nodes. 5 will be your posterior cervical lymph nodes here, posterior. Okay, and 6 will be your anterior group of lymph nodes here, alright. And 7 will be your mediastinal lymph nodes below the clavicle here. Okay, so these are the 7 groups of lymph nodes you must be able to palpate in a patient, in this patient here. Okay, so you got your submental, submandibular, deep cervical, upper, middle, and lower, and then posterior lymph nodes, anterior lymph nodes, and mediastinal lymph nodes here. Okay, this is another view, anterior view, more clearly shows level 1 is your submental and submandibular lymph nodes here. Level 2 is your upper, and level 3 is your middle jugular lymph nodes or the deep cervical lymph nodes. And level 4 will be the lower jugular lymph nodes or the lower deep cervical lymph nodes. Level 5 will be your posterior triangle lymph nodes here, here also posterior triangle, and level 6 will be, as I say, anterior lymph nodes here, anterior space here, also known as the visceral space, and thyroid is located in this visceral space here, anterior space. And level 7 is superior mediastinal lymph nodes below the clavicle here. Okay, so this is a very important picture that you must memorize and recall whenever you are examining a patient with neck swellings. Okay, now what are the general causes of cervical? There are two groups, thyroid and non-thyroid. Thyroid will be the most common, and how you differentiate this? It moves with swallowing. So ask the patient to drink some water, it moves with swallowing. Okay, non-thyroid does not move on swallowing. So if the swelling does not move on swallowing, very simple, then it is of non-thyroid origin. Okay, so what are the thyroid swellings that can present with? Normally adenoma, thyroid cyst, multinodular goiter. Adenoma and cysts are usually solitary nodules, multinodular, multiple nodules. It can be diffuse goiter. Okay, these are important things. Goiter. Then thyroiditis also cause inflammation of the thyroid. Okay, Hashimoto's thyroiditis, for example, and this causes enlargement of the thyroid, and also at the same time, it is also causes tenderness. Very pain and tenderness. Malignancy, the four types: papillary, follicular, medullary, and anaplastic. And usually they are solitary nodules, can be multinodular, and the features are usually they are hard in consistency, non-tender, and immobile. Okay, and the borders are not clearly demarcated. The surface may be irregular. So when these features are there, you have to think of malignancy. And most common is your papillary carcinoma. Another group of tumors is lymphoma. Lymphomas can be primary lymphomas arising from the lymph nodes in the neck, or it can be secondary metastatic deposits from tumors from elsewhere. Okay, so that is your lymphomas from other places come and be involved in the thyroid. Okay, next is non-thyroid swellings. As I said, do not move with swallowing. Cervical lymphadenitis, lymphoma, sebaceous cyst, congenital causes like thyroid glossal cyst, cystic hygroma and bronchiosis, and metastatic cancer. Okay, so deposits from the lung, breast, and abdomen. Okay, so these tumors can commonly spread to the metastatic, and I'm sure you're very familiar with the term Virchow's lymph nodes. Okay, this slide summarizes what I've been telling you all this while. In examination of a patient with the neck swelling or thyroid, you've got three main aspects in the examination. First is history, getting a very good history. Okay, swelling, onset, pain, progression, pressure symptoms, altered function, metastasis, and constitutional. These are important, which I already gone through. Second is physical examination. Okay, look for signs of thyroid problems. From the back, from the front, back and back to front. Okay, inspection and palpation. You make sure you greet the patient, position the patient, usually sitting. From the front, you inspect, palpate, and swallowing and protrusion, whether it moves or swallowing. Once it moves, that means it's thyroid origin. If it does not move, it is a non-thyroid origin. From the back, palpation of the lump, details of the lump, and palpation of the cervical 7 levels of cervical lymph nodes. Look for retrosternal extension, systolic bruit, and symptoms, signs of hyper or hypofunction of the thyroid. And the third one is a special test, which I mentioned: Spizillo's method, Pemberton sign, Barry sign, Cocker sign, Leahy's examination, Kryle's method, Horner syndrome. Okay, and these are all some of the important signs that you look for in patient tests to look for in patients with thyroid swelling. Okay, this ends my talk on this thyroid examination. The next part is a few videos on clinical examination of the neck. There are 3 short videos I want to show you. First one is a simplified, normal, short version, summarized version of examination of the neck, which is just 1 minute plus. Second one is your McLeod's examination of the thyroid gland. And the third one is your Oski examination techniques for thyroid swellings.
Thyroid examination. Examination of the thyroid gland starts with inspection. In doing so, it's important to consider the gland's anatomy and its surrounding structures. The thyroid cartilage is a helpful landmark, since the thyroid can be palpated bilaterally below it. In healthy individuals, the thyroid only weighs around 18 to 25 grams and should not be visible. An enlarged thyroid, otherwise known as goiter, is considered class 2 if macroscopically visible. When the head is reclined, thyroid enlargement can be seen even earlier. Palpation is usually performed from behind, although anterior palpation is also feasible. The gland is often only detectable upon palpation if a pathology is present, such as nodules, enlargement, or an altered consistency. You should also note any tenderness to touch, as seen in inflammatory changes such as a viral infection. To assess the mobility of the thyroid gland, ask the patient to swallow and offer a glass of water if necessary. If thyroid perfusion is increased, like in Graves' disease, examination may reveal an auscultable bruit and a palpable thrill.
Hello, Abby. My name's Amy. Would it be okay if I examine you?
Yes.
Inspect the neck from the front, looking for a goiter.
Could I ask you to confirm your name and address?
The voice can be characteristically slow in severe hypothyroidism.
Please, could you hold your hands out for me?
Look for fine tremor and feel for sweating, which may occur in hyperthyroidism. Carpal tunnel syndrome can complicate myxedema, and you may see hand changes of thyroid acropathy. Assess pulse rate, rhythm and volume. Tachycardia and atrial fibrillation can be features of thyrotoxicosis.
Keeping your chin still, could you look at my finger and follow it down?
Check for lid lag. You may need to give a bigger target if the patient's vision is poor. Look for proptosis. This is best seen from above. The thyroid or a thyroid mass moves up on swallowing. Supply water for the patient to sip to demonstrate this.
Please, could you take a sip of the water?
Observe the neck from the front during swallowing.
I'm gently going to examine your neck.
Stand behind the patient and gently feel the regions of the thyroid gland. Then place your hands over the gland with the index fingers just touching.
Could you take a sip of water for me, please?
Feel the gland as it moves up and then back down during swallowing.
Thank you.
Note the size, shape and consistency of any goiter and feel for a thrill. Listen over the 2 major lobes for a bruit. If there's a large goiter, use a tape measure and record the maximum neck circumference. Lastly, look at the legs for pretibial myxedema.
Thank you.
Okay, in this slide demonstrates the examination of the thyroid as required in the Oski examination.
Hello there, my name's Andrew. I'm one of the final year medical students. Could I confirm your name and age, please?
Hi, I'm Simon and I'm 24 years old.
Nice to meet you, Simon. Today I've been asked to examine the thyroid gland in your neck. Would that be okay?
That's fine.
This will just involve me generally inspecting, then I'll move in closer to the neck to have a closer look, and then have a feel of the neck as well. Is that alright?
Sure.
That's great. Are you comfortable where you are?
Yeah.
Fantastic. We'll start. Simon, if you could just bring your arms out in front of you like this and splay your fingers. Fantastic. I'm just going to lay a piece of paper on the hands. If you could turn your hands over for me. Finally, I'm going to feel your pulse. Thank you. I'm now going to look more closely at your eyes. If you could just pick a point on the wall behind me. And now I'm just going to look from the side. And I'll now look from behind. If you could just look slightly up for me, Simon. We're just going to do some movements of your eye now, Simon. So if you could just follow my finger, do let me know if you have any pain or double vision. That's great. Again, if you could keep your head still and follow my finger for me. Thank you. I'm just going to more closely inspect your neck now. If you just stay as you are. And if you could just take a sip of this water and hold it in your mouth. And swallow. Fantastic, Simon. If you could just stick your tongue out now. I'm now just going to feel your neck as well. If you could just stick your tongue out for me, Simon. That's great. And if you could just take a sip of the water for me. And swallow. I'm just going to feel the glands in your neck. Fantastic, thank you. I'm now going to feel your windpipe. It might be a little bit uncomfortable. I'm now going to tap on your chest. And finally, I'm going to listen. If you could just take a deep breath and hold your breath there. And breathe normally. Simon, I'd just like to finish with some special tests. So we're going to start with the reflexes in your arms. If you could just relax your arms on your lap like this with your palms facing to the ceiling. Fantastic. I'd just like to look at your shins, if you wouldn't mind rolling your trousers up for me.
Sure.
Fantastic. And finally, if you could stand up, but first I'd like you to cross your arms for me. And relax. This completes the examination. Thank you very much. Today I examined Simon Sayers, who's 24 years old. On general inspection, he had a fine tremor of his outstretched hands, but there were no other peripheral stigmata of thyroid disease. There was no evidence of thyroid eye disease and no goiter. To complete my examination, I'd like to do some blood tests and look specifically at the T4 and TSH levels.
Okay. For more information on other aspects of thyroid, please do not hesitate to visit the sites on the YouTube. Thank you. Hope to see you again. Next, we come to a few OSCE questions on thyroid examination. First question. A 28-year-old man complains of a swelling over the right side of the neck for 1 year. What further details of the chief complaint of this patient would you want to obtain? Secondly, what other symptoms will you ask for in the patient? The answer is the questions about the chief complaint that I want to go ask for details will be the onset of the chief complaint, onset of the swelling in the neck, progress of the neck swelling, whether it's pain or painless, nature of the swelling, does it move with swallowing, does it move with protrusion of the tongue, and whether it is solitary or diffuse. Question number 2, what other symptoms will you ask this patient? First of all, I'll ask for pressure symptoms, hoarseness of voice, dysphagia, breathlessness, and stridor. Secondly, I will ask for functions of hypo or hyperfunction of the thyroid. Okay, whether this patient has got the features of thyrotoxicosis. And thirdly, will be the symptoms of malignant change, such as pressure symptoms, sudden onset of pressure symptoms, sudden increase in size, sudden increase in pain, and constitutional symptoms, and loss of weight and appetite. On physical examination, the question C, the physical examination, describe what you see on inspection of the neck of the patient as shown in the patient here. Okay, the answer to this question will be there's one large nodule here on the right lower neck, size about 2 to 3 centimeters, maybe bigger, and is well defined and no skin changes. Question D, describe how you will palpate the neck of this patient. The answer is the patient is palpated sitting on a chair. You inspect from the front, side, and again from the back, and see whether it moves. The swelling moves with drinking sips of water and protrusion of the tongue. So these are the important features that you will look for. At the same time, on palpation, you will also want to look for confirm the size of the lump, and as well as whether the other features like consistency, the surface, the border or the margins of the lump, and whether it moves on swallowing and whether it moves up and down when on palpation. Question E, what investigations will you do for this patient to help in the diagnosis? I will do a thyroid function test or TFT, which consists of a T3, T4, and TSH. I'll also do follow-up with an ultrasound scan of the neck and the lung, and proceed on, if necessary, with a fine needle aspiration, FNAC, under ultrasound guidance. In this patient, if necessary, I will also do a chest X-ray to see the deviation of the trachea. Okay, the question number 2. This is a picture on the left here, shows of a 60-year-old woman. Okay, picture of the neck. Describe the findings on inspection. The answer, there's a large goiter involving the whole of the thyroid gland, both the right lobes, left lobes, and the isthmus. It is multinodular and large, and the surface seems to be smooth. What is your diagnosis? Large multinodular goiter. What are the symptoms of possible complications of this lesion? First, you have the pressure symptoms, hoarseness, stridor, and dysphagia. Secondly, symptoms of malignant change, rapid enlargement, pain, heart, and pressure symptoms. Pressure symptoms as mentioned earlier, and also constitutional symptoms with loss of weight, etc. Thirdly, toxic symptoms such as hyperfunction, thyrotoxicosis symptoms, eye signs, generalized symptoms. These are all very important to go through in this patient. And fourthly, hypofunction, whether she has got features of hypothyroidism. Okay, so thank you for joining me for this session on examination of the thyroid. For further information on this topic, you may visit these various links given here and in my various Facebook and YouTube channels. Thank you.